Okay, now we're going to look at sinus bradycardia, meaning slow heart, because brady means slow. This is still going to be rhythms that are originating from the sinus node themselves. And we always know when something comes from the sinus node because we get that normal rounded sinus P wave. Now, sinus bradycardias are generally a regular rhythm. Sometimes it might be slightly irregular, but overall it's considered a regular rhythm. The rate will be less than 60, so 60 is normal, 59 or slower is going to be a bradycardia. We'll have one P wave for every QRS, and it should be a nice, normal, rounded, symmetrical P wave. We should have normal PRI intervals and normal QRS intervals. Now, QT intervals, we've mentioned that normal is 0.40 or less in normal heart rate ranges. In bradycardias, sometimes that QT interval will lengthen in bradycardias. It's abbreviated SB for sinus bradycardia, but you always want to make sure you put the rate because, again, sinus bradycardia at 58 versus sinus bradycardia at 30 are going to be two different things. So in this example here, in my 6-second strip, I have R to R is regular. My rate is only 30. I have a P wave for each and every QRS. My PR interval looks like it is 1, 2, 3, just a hair over 3 boxes. So 0.12, 0.14. QRS looks like it is about 2 boxes, so 0.08. Now my QT interval from the beginning of the QRS to the end of the T wave here, it looks like it is 1, 2, 3, 4, 5, 6, 7, 8, 9. It looks longer than that. Looks like one of my lines here didn't show up here. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So it's about 0.40. So that's okay. So it would be SB at 30. Now, our next rhythm strip here, again, regular rhythm. R to R to R is regular. In 6 seconds, I have a rate of 30 again. I have a P wave for each and every QRS. PR interval looks like it is, well, it looks like it's 1, 2, these boxes just don't look right. Unfortunately, when I put strips in my PowerPoints, it kind of skews my background on this, so it makes it look a little bit fatter, but it looks like it's probably about 3 boxes worth. QRS, now my QRS here looks like it is 1, 2, it looks like it's almost 3. Now you can have bundle branch blocks. When we discuss bundle branch blocks, and bundle branch blocks are just a variant of a wide QRS. So when you have a delay down that conduction system. And I know it's not anything more than a bundle branch block because I have a sinus P wave in front of it. So I know this rhythm is coming from the sinus node. I can have bundle branch blocks with sinus bradycardias, with sinus tachycardias, with sinus rhythms. So it looks here like I might have a sinus brady at 30 with a BBB, a bundle branch block. Now this one here, I have a regular rhythm. Oh, and just to mention as well, bundle branch blocks, we don't treat them. They don't usually, unless it's something new. So if you have a patient who never had a bundle branch block and now all of a sudden they have one, then I might be concerned that maybe there's some event causing it, that maybe they're having some damage that's impacting the conduction down the bundles. But if it's something that they've always had and some people just have that as a variant, it is not anything we treat. The problem being with bundle branch blocks, I don't know if you remember, but with bundle branch blocks, we talked about how you can get those secondary ST and T wave changes a lot of times with bundle branch blocks. And when you have bundle branch blocks with the secondary ST segment and T wave changes, then it's really hard to determine if you're having a cardiac event. If a person's having chest pain and they have a bundle branch block, do they just have a conduction defect or are they having, a cardiac event? So that can always make it really tricky when we are having chest pain with the bundle branch block. Because again, secondary ST and T wave changes are just part of the bundle. So this one here, I have a regular rhythm. My rate is 1, 2, 3, 4, 5, so a rate of 50. I have a sinus P wave for each and every QRS. My PR interval looks like it is 1, 2, 3, just a little over 3 boxes, so about 0.14. QRS looks normal. It looks like it's a normal width, and it looks like it's about 0.06. And my QT interval looks like it's 6, 7, 8. It's about 0.36. So I would chart that SB at 50. Now this one here, again, regular rhythm. R to R to R is regular. My rate is 1, 2, 3, 4, so rate of 40. Have a P wave for each and every QRS. PR interval looks like it's 1, 2, 3. It looks like it's almost 4 boxes, so 0.16. I think that's what I'm seeing here. QRS looks like it's about 2 boxes, so 0.08. Now QT looks like it might be a little bit longer than that. QT interval looks like I am 1, 2, 3, 4, 5, 6, 7, 9, 10. It looks like I'm almost 11 boxes, I think. If I'm counting these right, it's really hard for me to see these. They're a little blurry. So 0.44. So again, sinus Brady at 40. Now this one here, again, regular rhythm. My rate is a rate of 30. I have a P wave. Now my P wave goes up and it comes down a little bit. So I've got the little blip in it. Now, usually very normal in an MCL1 lead, which is probably what I'm in by the looks of this. So if I'm in an MCL, okay, I've got a regular rhythm here. I've got a rate of 30. The fact that my P wave goes up, down, and like has a blip in it, no problem. PR interval looks a little, it looks like I'm 1, 2, 3, 4. It looks like I'm 5 boxes, so it looks like I am going to be about 0.20. Now my QRS, it goes up and then it comes down for a deep QS. And it looks like it might be a little wide. 1, 2, it looks like it's about 3 boxes, which would give me a bundle branch block. And because I'm in MCL, I can determine that that would be a left bundle branch block because we said right bundles, I would have the RSR prime. Left bundle, I would have a caret left in the ground. So I would chart this SB at 30 with a BBB. Now, what's my biggest significance of this? Truthfully, my rate's 30, and that's what's going to cause the problems for the person. So what things can cause a sinus bradycardia? Physiological causes, it's normal for athletes. So if you are a marathon runner, you go to the gym and you work out a few hours every day, your normal resting heart rate is probably going to be in the 50s. I mean, that's really typical with athletes. Sleep, it is normal for your heart rate to drop about 10 points in sleep. But keep in mind about 10 points, maybe 15 at max. So if your patient you're taking care of is normally sinus rhythm in the 90s, and now all of a sudden they are sinus brady at 50, there's a problem. But if they're normally sinus rhythm in the 60s and now they're asleep and they drop down to sinus brady in the 50s, I know that that's probably just because of sleep. Vagal maneuvers, bearing down, coughing forcefully. Okay, and one of the things that we see a lot of times is cardiac patients, because their heart's already in a weakened state, and a lot of times they haven't been eating their normal diet. They haven't been exercising like they normally do. They may have been taking pain medications. So sometimes they get a little constipated. You get them up to the bathroom and they bear down. They push really hard trying to have a bowel movement. They stimulate that vagus nerve, which actually slows down the heart rate. And it can make them pass out in the bathroom. I mean, it happens so often. We call them code commodes. And so that's something to keep in mind when you have a new cardiac patient or an open heart surgery patient. We need to think about, hey, maybe we need to give them some stool softeners. I mean, yes, if their stool starts becoming loose, we could stop them, but we don't want to wait until they get constipated to have a problem to start them. Pathological causes, increased intracranial pressure can do this, or an acute heart attack, an acute MI can do this as well. Now, there are some medications that can cause bradycardias as well, and we give a lot of these, especially on cardiac floors. Digoxin. Now, DIG used to be an exceptionally common medication that you would see given in a hospital. You work on a tele floor, it wasn't unusual to see half of your patients or more on digoxin. There's so many other medications out there that don't have all the side effects that DIG does, that you're still going to see digoxin used a lot, but maybe there's a lot of other choices out there now. Beta blockers, your metoprolol, your propranolol, all your beta blocker drugs, those are very common to see on a cardiac floor. Common for blood pressure management, common for arrhythmia management. And again, their side effect is to slow the heart rate down. So it's one of the reasons with DIG, with beta blockers, you're always supposed to check an apical heart rate before you give it. Calcium channel blockers, diltiazem, very common medication to use. And morphine, okay, a lot of our patients, especially let's say they've had open heart surgery or they've had some kind of procedure and we're giving them a lot of pain control management, that can also slow a heart rate down as well as respiratory centers. So what do we do for sinus bradycardia? For one thing, we want to always make sure with the sinus bradycardia is we're only treating it if they're symptomatic. Again, you can have someone who's a sinus brady at 40 and feels perfectly fine. It doesn't mean I'm not going to still look for the cause of it, what's causing them to be in a bradycardia. But if they're in a sinus rhythm at 40 and they feel absolutely fine, I don't need to be pushing medications to make their heart rate go up. I just want to find out why their heart rate's slow. Is it the medication they've been taking? Is it because they're an athlete? What's causing it? Significance of a slow heart rate? Well, increased pumping action in response to the slow rate, and that can cause oxygen demands to change. So again, remember our cardiac output, it's based off of stroke volume times heart rate. Stroke volume shouldn't be impacted with this. Your heart has time to fill properly. It has a good diastolic phase to it, but it's also times your heart rate. And if your heart rate's only 30 or 40, you're going to decrease your cardiac output. And decreased cardiac output can give you dizziness, syncopal episodes, altered level of consciousness, chest pain, shortness of breath, drop in blood pressure, diaphoresis. So if the person's having a decreased cardiac output, then we need to think about treating them. Now, your treatment's going to depend on what your protocols are. So if you work on a monitored floor like an intensive care unit, on a telemetry floor, a lot of times you will have standing protocols. So you always want to know what the protocol is on the area where you work. But generally, treatment of choice for a symptomatic bradycardia would be atropine, 0.5 milligrams IV push, and you can push it rapidly. So we give atropine 0.5 milligrams. It can be repeated every 3 to 5 minutes to a max dose of 3 milligrams. So basically 6 doses. Well, if 1 and 2 isn't taking care of it, we need to think about giving them something else. Okay, but atropine is generally treatment of choice. Patients may need an external pacemaker. So we'll be looking at our crash carts probably next week or the following week. We're going to take a look at what our crash carts look like. And one of the things that our crash carts do is they not only defibrillate and cardiovert, but they can do external pacing. So that's another treatment for it, is we can pace the person until they decide what's going on. And we'll talk a little bit in a later class on how to do our pacemaker. Dopamine drip. Now, a dopamine drip is not usually done on a floor. Usually they're going to need to go back to the intensive care unit. But dopamine supports the blood pressure. It's an inotrope, and it will support the blood pressure. We usually give 2 to 20 mics per kilogram per minute. The side effect of dopamine is it speeds the heart rate up. So if you have bradycardia and they're hypotensive with it, dopamine may be a good choice for them, but you always want to make sure you've got a really good IV access. Dopamine, if it infiltrates into the veins, it can cause necrosis of the tissues. And then epinephrine drip, not an epi push or an epinephrine shot, but actually an epi drip. We can give an IV 2 to 10 mics per minute, and that can be used as well. And I would say that's not as common. It's very common for the atropine, for an external pacemaker, or for dopamine. Now, external pacemakers, I do want to say they're only meant to be temporary fixes until you can get a permanent pacemaker or a transvenous pacemaker in them. They're very uncomfortable for the patient because it's pacing them through muscle, through bone, through fat, and so it takes a lot of current to do that. And their whole body's jerking with the paced beat, and it's just, they usually need some sedation to go along with that external pacemaker. But it is a good choice if that's what's needed. So we will stop there and take a little break.